and interacting. I'm not going to present it in the conventional way, the types of cough, blah, 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 and causes of cough, blah, blah, blah. No, we're going to give a lot of clinical scenarios, which would be an interactive scenarios as the case presents to the doctors or the healthcare providers. Of course, the cases will have some twists and some mysteries, as any clinical cases, and how to treat these cases. And of course, I'm going to give a lot of discussion in each cases. And the three cases that I'm going to present are very, very common and very, very important, yet a bit too mysterious and a bit tricky in management and diagnosis. So what is cough? We have to, before we start with the clinical scenario, have to introduce what is cough. Cough is actually a kind of a sudden and often repetitive reflex. Actually, it's a defensive body reflex to help to clear the throat and, the most important, the airway of irritants, mucus, or foreign particles to defend the airway. It's a very common symptoms of various respiratory conditions and infections. Why we make a fuss for cough? Cough is a very common to reach a proper diagnosis. So why the cough is very important to know it very well and understand it and clarify it very well. That's I'm going to give some messages not only for the healthcare providers, also for the patient. Number one, recurrent or persistent cough can be symptoms of various underlying health issues. Mild things like common cold, allergies, to serious symptoms, serious situation like asthma, pneumonia, even lung cancer. So it could be a mild symptoms, at the same time it could be the tip of the iceberg. So that's why it's very crucial and important, and usually we should be alarmed from it. Number two, effective communication with the patient and healthcare providers. History is very important. Sometimes also history can make you reach the diagnosis faster and even more than the clinical examination. You have to take your time with the patient. You have to ask every single details, because every single details make a difference. How cough comes, how it started, what triggers it, what is accompanying symptoms, which part of the day which is become more aggressive. We need to, and if so, you have to, even if the patient didn't answer the things, you have to make some sort of guided questions. You have to be very, 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 very careful, and very, very details really makes a lot of difference in this in cough diagnosis and management. As also as I can reveal this in the case scenario that I'm going to present. Cough also affects, like any other many symptoms in life, it affects quality of life. If you have a chronic and persistent cough, it will affect your sleeping, and it will affect your daily activity, and also affects you psychologically, because everyone will consider that you are infectious, especially after the era of COVID. No, this person, maybe you have some sort of allergic cough, but everyone will consider you infective or consider you ill. So it's affected physically and even psychologically. That's why it should be addressed and treated properly. Again, if you have cough, you might be also a sign of or symptoms of you have the infectious disease. So you have to take your precautions to not to transmit the infections to others. And you have also to teach our patients how to take the precautions and how to do the infection control precautions, how to, if you cough, so because a lot of infections come through droplets, and droplets come when you cough, how to deal with this situation. We have, everyone knows, and everyone knows from the medical and non-medical, they should know the precautions to prevent infectious disease caused by droplet, caused by cough. Also, cough could be something mild, so and also something alarming. So the role of the healthcare providers is either to assure the patient or to alarm the patient according to the situation. Assure the patient if the cough is only some causes of allergy or common cold or a simple disease, or a treatable disease, or go with after treatment after a while, or alarm the patient. No, this cough is really of serious condition, and we have to be alarmed, and we have to do further investigation, and we have to take the treatment properly, and we have to follow up. So according to the clinical situation, is it alarming or assuring? The sixth message is to the patient themselves, that you have to understand your body well, understand when you have symptoms like cough, that could be underlying problem or underlying clinical condition, and you have to address it, and you have to go to the required. Also, for chronic condition like asthma, the understanding cough patterns can help you in monitoring the effectiveness of the treatment. So you, as a patient or as a healthcare providers, from the severity of cough or from the frequency of cough or from the type of cough, you can know that your treatment is progressing in a good way or maybe you need to change it. So it's also a kind of a follow-up or a tracking progress. Also preventing complications, certain cough, especially if accompanied with other symptoms like chest pain, difficulty in breathing, or coughing up blood, can indicative of serious underlying condition, what's called the tip of the iceberg. So you have to be alarmed with these symptoms. As I mentioned before, cough either assuring or alarming. So we take usually cough seriously. Cough could be the tip of the iceberg. This is the first message I want everyone to take. In summary, understanding cough is a fundamental aspect of maintaining good health. It facilitates effective communication with healthcare providers, enables timely interventions, and empowers individuals to make control of their own well-being. So we'll start with the scenario, and there will be some quizzes and poll, and I'll give you time to answer the poll. I will try to. The cases is very clear, and as they present to the physician, I will mention all the investigation done. Think properly. Case number one, Mr. John Doe. He's a 32 years old male working in an office work. Chief complaint is a persistent cough. Mr. Doe presents with a persistent, dry, irritative cough for the past 3 weeks. He reports that the cough started after he recovered from a viral upper respiratory tract infection characterized by rhinorrhea, mild fever, and sore throat. Be careful, everybody. Every word and every letter makes a difference. So clearly read it and clearly understand it. So his history of present illness, the cough is dry, as I mentioned, non-productive. He denies any sputum production. He describes occasional episodes of postnatal drip, and occasional, not persistent. Sometimes it happens. This is very important also. He denies any shortness of breath, denies any chest pain, and denies wheezing. Mr. Doe reports no history of smoking or exposure to environmental irritants. His past medical history, there is no history of asthma, no history of chronic obstructive pulmonary disease or other chronic respiratory condition. And there is no significant medical history apart from occasional seasonal allergy. Family history, there is no family history of respiratory conditions or significant allergy. He is a non-smoker and denies alcohol or illicit drug use. Physical examination, all his vitals are normal. Generally, Mr. Doe appears well nourished and in no apparent distress. Upper respiratory tract, all normal. ENT examination, absolutely normal. Chest examination, there is clear breath sounds bilaterally, no wheezing, no crackles. We have done chest X-ray. Everything is normal, no signs of consolidation or infiltrate. We think also pulmonary functional tests, all within normal. Spirometry, allergy tests are all negative for common allergens. So in summary, Mr. Doe presents with lingering, dry, irritative cough. Otherwise, everything apparently normal. And the cough is really, really irritating. So question number one, everyone will answer the poll. Choose the most applicable diagnosis. Is it a cough variant asthma, number one? Choice number two, is it a post-viral cough? Choice number three, is it a chronic post-nasal drip? I'll give you time to answer the poll. Remember the case. It started as an upper respiratory tract common cold. Then he had this cough, which is a lingering cough. Everything is absolutely normal. All his investigation is normal. chest examination normal, ENT examination is normal, breath test is normal. What you expect? This cough is a very common, by the way, and unfortunately, it's usually under thought. People don't. A lot of this case usually comes to the doctors. Usually, unfortunately, wrong medication is given, and patient goes from medication to medication to medication. All cough syrups are taken. Everything is different. So I just want to know the answer.
Dr. Shinawi, you can see the answer in the chat.
Yeah, I can see that 62%, as I can see, I just want to increase the thing, the picture a bit. We'll go for the second answer. And about 28% go for cough variant asthma, and only 6% or something or minor go for postnasal drip. Yeah, I think that's a good, most of you got it right. This is a case of post-viral cough. And unfortunately, some misdiagnosed it, but unfortunately in real life, it is misdiagnosed. So post-viral cough is I wanted to talk about it in full details and how we, and of course the treatment also has another poll, but I want to discuss it in more details and what is the peculiarity about it. So as what happened to Mr. Joe, it started as a common cold, and then cough started, a dry, irritative cough, which is really up to 3 weeks. Sometimes it lasts up to 3 months. Then everything apparently is normal. Everything is apparently normal. This cough is peculiar by the following. It's usually said, all the patient will say this, before this cough starts, I feel that there's something, someone is tickling my trachea, and after that the cough starts. And when the cough starts, it keep going. There are some also triggers, like if I cough, if I laugh, or if I talk, or if I breathe, or if I do exercise. Another peculiar when you lie down, sometimes we are, but once you go to deep sleep, it's over. So I always ask the spouse if his wife or her husband cough at bedtime when she or he falls asleep, that they wake up from cough, they always deny that. No, once the patient sleep, the cough is over. And the patient will tell you that I feel that most of the irritation in the area of the trachea and area of the larynx is a very distinguishable part of this cough. I don't feel it is not a chesty cough. I feel there is irritation here. And I feel there's something tickling, and I cough. One of the peculiarity also of this kind of cough, it's sometimes some patient, whenever they get any common cold, not every common cold they get, they develop the post-viral cough immediately after. By the way, it's not uncommon. It's very common, but unfortunately, it's always misdiagnosed. And a lot of long treatment is, and by the way, it is treatable, and it's also preventable, and also there are prophylactic for it to happen in the future. So people who are prone to have this kind of cough, there is a kind of medication I always prescribe. Whenever you have cold before the cough starts, take this medication. So this is a case of a post-viral cough, which is common. As I told you, it's a kind of dry, irritative cough, usually follow common cold or any not necessarily common cold. That's also the best term for it is not post-viral cough, it's post-infective cough. It comes as a sense of irritation in the area of trachea, and always preceded by a sense of tickling in the trachea. And there is also triggers like talking and laughing and okay, so it's a case of post-viral cough. How to manage it? So question number 2, choose the only non-applicable. There is a lot of medication you can give, and I'm going to discuss, of course, after seeing the poll, how we treat these cases properly. Choose the only non-applicable medication to treat this post-viral cough. So most of them are applicable except one, non-applicable. Number one is cough suppressant. Number two is ketotifen mast cell stabilizer. Number three, oral steroids. Number four, mentoleucast. Number five, pregabalin, which is Lyrica. Number six, inhaled steroids. I'll give you time to answer this question. This peculiar illness has also some sort of peculiar treatment, and a lot of medication can help. And also you can make it at plans A, plan B, plan C, plan D. I'm going to discuss how we treat these cases after seeing the answer in your poll. As I mentioned, it's very common and unfortunately misdiagnosed and unfortunately mistreated. So this is a very, very important question and a very important discussion that I'm going to discuss it in full details and how I deal with these cases. Okay, are the poll ready?
Dr. Shinawi, you find the answers in the chat.
Yeah, in the chat, yeah. So there are division here. Most of the cases said the most applicable, non-applicable is cough suppressant. Few said ketotifen, few said oral steroid, few said mentoleucast. A big branch of them tell you pregabalin, okay, and a very few said inhaled steroids. Unfortunately, most of you answered wrong. The correct answer is inhaled steroids. There is no role for inhaled steroids in post-viral cough or post-infective cough. That's why I told you these cases are always misdiagnosed and always mistreated. So how we treat this kind of post-viral cough, I want you to listen in what I'm going to say in full details, because it's very, very, very important and very, very crucial. And this is an important message. The second important message I want you to take home. When you have a case like this, and most of you diagnose it as a post-viral cough or post-infective cough, how we start? Okay, we can start with cough suppressant. Cough suppressant is not a bad idea. Try cough suppressant, especially cough suppressant, which usually works against dry cough. Start with it. We will see and tell our patients, okay, hydrate well and things like that. Usually, to be honest, sometimes it works, sometimes it doesn't work. The next treatment I prefer, or this plan B, I give the ketotifen. The ketotifen is mast cell stabilizer. It really works. It really works very good in this kind of cough. Not only that, ketotifen also can be given as a prophylactic for this cough. So I usually ask the patient, you are prone to have this kind of as I mentioned, some patients are prone to have this post-viral cough whenever they have an infection or whenever they have viral infection. So when you start to have the scratchy throat, when you start to have a sniffly nose, take the ketotifen. So this will prevent. Usually I give them for a period of 1 week, and really, really it prevents them from having cough. Sometimes it doesn't work. So we go to plan B, or sometimes I go direct to plan C. I'll give oral steroids or mentoleucast. Mentoleucast is, you know, that it has also some side effects, that it have mood changes, and some people have also that it make nightmares, and it make some suicidal tendency. So to be honest, I prefer oral steroids with its possible side effects than mentoleucast. Oral steroids, I usually give it for a period, for a week period, and when you give it for a period of a week, there is no need to do gradual tapering, except of course if there is a contraindication for the oral steroids, like diabetes or like peptic ulcer. You cannot give oral steroids, so think of giving the alternative like mentoleucast. Oral steroid usually in 80% of cases or 90% of post-viral cough are effective to treat this post-viral cough. So try with cough suppression. I'm sure the patient, when he comes to you, he's tried already cough suppressant, but usually it didn't work. So think of the plan B, ketotifen. Ketotifen also you should give it as a prophylactic whenever the patient has any sort of upper respiratory tract infection or anything, start the ketotifen immediately to prevent him or her from having the cough. If it didn't work, give oral steroid for 1 week or Montelukast. Then, in some cases, like 10 to 15% of cases, even with the steroids, it's not working. They tell you, they're frustrated. Doctor, still have the irritative, horrible cough. You know, there are some medications mysteriously treat some. You know, like minoxidil in treating baldness, or Indral on treatment of migraine. Pregabalin, which is treatment for epilepsy, also for neuropathic pain, have found have a good advantage of treating of resistant or persistent or refractory case of post-viral cough. So whenever you have, of course, it's a controlled medicine. It should be given with precautions and only given to adults, not given to children. If you have a person, we have post-viral cough, which is really, really refractory to medical treatment. You've tried everything and it's still persistent and still there. Try pregabalin. Give it in the low dose. We usually give 75 milligrams twice a day for 1 week. And in 1 week, it will sure treat this post-viral cough. It appears very strange how to give this treatment and cough, but it works, and it works. So the inhaled steroid is the treatment which has no role, because unfortunately, most of the patients with post-viral cough are treated with inhaled steroids and nothing happens. So don't waste your time and don't waste the patient time by prescribing inhaled steroids, specifically if you are assured that the breath tests are normal and there is no wheezing in the chest of the patient. So this, we are through with the case number 1, or scenario case number 1. I'm willing also to hear a lot of questions about it. Now we go to case number 2. We have Mrs. Fatma Ali. She's 56 years old, female, as a retired teacher. Her chief complaint is persistent dry cough for the past 6 months. Mr. Fatma describes her cough as non-productive, purely dry, occurring mainly during the day but worsening at night, especially when she lies down, with some choking episodes. She denies any history of respiratory infection, any history of wheezing or shortness of breath. She's non-smoker, non-alcohol, and no known of environmental exposure. Family history: there is no significant family history of respiratory or gastrointestinal disorder. She has negative fever, chills, weight loss, night sweats, chest pain or dysphagia. General, well-nourished, no acute distress. Vital signs: blood pressure is within normal, heart rate 72, respiratory rate 6, everything, temperature is normal. Head and neck, only there is some moist or congested oral mucosa, and take this as an important thing. There are some congested oral mucosa. There is no cervical lymphadenopathy, and there is normal conjunctiva. Cardiovascular, irregular rate rhythm and no murmurs. Respiratory, clear breath sounds bilaterally, no wheezing or no crackles. Abdomen, soft, non-tender, non-palpable. Other things is normal. You have done a chest X-ray, absolutely normal. You have done a lab blood test. There is a complete blood CBC, and everything is considered normal. And her H. pylori test is negative. So choose the proper diagnosis. A lady has a cough for a long time, and the cough is worsening at night time, and specifically when she lies down. This is a cough which is really worse, and with some choking episode. This is important. And when it's the only positive thing is she have a congested oral mucosa. Is it a case of a silent gastroesophageal reflux disease? Is it a case of spasmodic cough? Or is it a case of drug-induced cough, drug-induced cough by antihypertensive? I mentioned that this lady is hypertensive, and she's on a certain medication, amlodipine. Antihypertensive, also some drugs, antihypertensive, known to cause irritative cough. I want the answer. And I mentioned that the antihypertensive she's taking is amlodipine. This is very important. And there are episodes of choking. And the case is usually worse, the cough is worse at night, especially when lying down. All these are pathognomonic and very important. I'm waiting for your answer. Yeah, there are confusing here. You see, most of it, most of you, about 64% diagnosis as a silent GERD. Plenty of you diagnosis as spasmodic cough, and also 26% diagnosis as drug-induced cough. Let us, my first reply is drug-induced cough. The drug, the antihypertensive, which causes cough is the ACE inhibitor. You have to ask the patient what kind of medication in full details you take, or just to know. So the only antihypertensive is ACE inhibitor, not a calcium channel blocker. This is not a case of spasmodic cough because there is no spasm when she feels. This is a case of a silent GERD. And a lot of cases is really confusing. There is no GIT symptoms. I don't have heartburn. I don't have regurgitation. I don't have anything. And that's why I've told you all the cases have some twists and some tricks, but this is how the cases present to you. But there are two pathognomonic things I mentioned to tell you that this is a case of GERD. The case is worse when she lies down. If any cough is worse when the person lies down, it's one of two. Either it's a postnasal drip or it is a reflux. So if the cough is worse, it's either this or that. The patient denies any history of postnasal drips, so it is this. Another pathognomonic sign is the presence of congested oral mucosa, because the refluxive acid also causes what's called reflux pharyngitis. So these cases, it's common. I think this is one of the most common cause of dry cough that you present, but unfortunately, in some cases, especially when they have silent, which don't have typical GIT symptoms, usually they are misdiagnosed and also mistreated. So this is the second message. When you have a case of a chronic irritative cough, more worsening when lying down, you should consider silent gastroesophageal reflux, even if the patient denies any symptoms of a GIT problem. So a case of, I told you, most of the cases are tricky and twisty, but they are very common. And this is what they present you. And that's why I want to take all these messages home. So choose the least applicable for this case. Now we diagnose it as a silent reflux, and I'm going to tell you how I treat it as an ENT doctor or as a chest doctor. I'm not a gastroenterologist. How I treat this case: number one, cough suppressant. Number two, proton pump inhibitors. Number three, hyaluronic acid. Number four, lifestyle modification. And hyaluronic acid, I mean the oral hyaluronic acid. So one of these are non-applicable. Three are applicable, one non-applicable. Think wisely and think properly. Which one is the least applicable in treatment of a case of a silent GERD or even a case of non-silent GERD? You see, there is a lot of confusion. Although these cases are common, there is a lot of especially the last question, most of you were really confused and they answered it wrongly, although this is very common. So a lot of messages I want you to take please home, so these cases will not be misdiagnosed in the future. So now let me reveal the poll. By the way, I said choose the least applicable. The least applicable, not the most applicable. The least applicable, the one you should not be given. Not some are really confused. Okay, many of them put a proton pump inhibitor, although this is the first line of treatment. Also, a lot of people put cough suppressants. A lot of people put hyaluronic acid, and lifestyle modification was less. So the least applicable, I mean the one which should not. Three are applicable, one is not applicable, as I answered. Okay. In case of gastroesophageal reflux, of course, we have to give the best treatment of proton pump inhibitor. We can also have to do some sort of lifestyle modification, and hyaluronic acid also act as a coating for the upper GIT tract, preventing or minimizing the reflux to go to the upper airway. What I do to these cases as follow, and I want you to do all the same. I ask the patient, I'm going to give you some, if I suspect that this is a case of a silent GERD, I tell him or her, I'm going to do what's called therapeutic test. It's a test. I'm going to give you medication. If it will not benefit you, it will not harm you. But if it will benefit you and all the cough symptoms disappear, this is 100% you have a case of gastroesophageal reflux. Next visit is not to me, you see a gastroenterologist. But if the cough persists, come back to me. So we give proton pump inhibitor, and because this is the first line of treatment. Sometimes we also add hyaluronic acid because it also it facilitate or make the treatment faster or accelerate the treatment and accelerate the day. But I usually tell the patient we will not find improvement except after 1 week. So don't expect any improvement for the first day, second day, third day, fourth day. Wait for a week. And the majority, 95%, really improved after 1 week. But you tell him that if you really improve, that proves that you have gastroesophageal reflux. Next visit is to the gastro. He or she is the one going to treat it properly and do endoscopy. Lifestyle also modification is very important for cases of reflux, that you should ask the patient never ever that always leave 3 hours gap between eating and lying on bed, because this will make the reflux worsen and make the cough worsen. As I mentioned, it is usually worsen when lying down. So second case, another confusing case, and I hope you took the second message. I told you the cases are really common, yet very tricky and very misty. So we go to case number 3. I believe this is a most simple case, but it's still one of common. And I want to discuss also something else when I finish with this case. We have Mr. Danish Sundram. He's a 42 years old gentleman, works as an engineer with no significant medical history. His chief complaint is persistent cough of the past 10 days. This is not a chronic cough, this is acute cough. Mr. Sundram described his cough as initially dry, take care of every word, but recently it has been producing thick, yellowish, green mucus. Also, the color makes a difference. He reports facial pain and pressure over the cheeks and forehead. This is good pathognomonic, particularly worsened when bending forwards. He denies any history of wheezing, shortness of breath, or chest pain, no fever, chills, or night sweat. This cough is worse also when he lies down and when he wakes up in the early morning. Remember, I told you causes of cough, which is worsened when the patient lies down. I told you 2. He's non-smoker, occasionally alcohol consumption, and no known environmental exposures. There is no significant family history of respiratory or sinus disorders. He is negative for fever, chills, weight loss, nasal congestion, or postnasal drip. When you feel them, generally, vital signs, blood pressure is 120 and 80. Heart rate is 72, respiratory rate is 18 per minute. Head and neck, there is mild tenderness of bilateral maxillary, no purulent discharge from nares. Mucopurulent nasal and postnasal discharge. There is mucopurulent nasal and postnasal discharge. There's no necessity to find discharge in nares, but there is mucopurulent postnasal discharge. Respiratory clear breath sound, bilateral, no wheezing or crackles. Chest X-ray is normal. Nasal endoscopy demonstrated purulent discharge from the middle meatus. By the way, some cases when you examine them clinically with just rhinoscopy, you don't find nothing. Then when we go with the endoscope, we will find that there is a lot of findings. His complete blood count, CBC, and basic metabolic panel are within normal. So I believe this is an easy case. What is the most appropriate? Is it allergic rhinitis? Is it acute bronchitis? Is acute bacterial sinusitis on top of viral nasopharyngitis on top of common cold? Is it a chronic postnasal drip? And I want also to discuss chronic postnasal drip in full details. So I'll wait for your diagnosis.
Now we need to skip the questions and go directly to the answers, please. Thank you very much.
All right, okay. So this is a case of acute bacterial sinusitis. It started with common cold, and a lot of cases usually have cold and followed by irritative cough, started a dry cough, followed by postnasal drip of mucopurulent discharge, which caused them to cough, especially when they're lying down. And especially when acute, you should consider acute bacterial sinusitis. We usually, also duration is very important because usually sinusitis starts as viral, then it ends into bacterial. So the duration is important. Usually after 1 week or after 10 days, if the condition is not improved, that's proof that it turns bacterial. Second thing, the color of the discharge is very important. So greenish or whitish is indicative of viral. When it turns to yellowish or brownish, this is indicating that the patient is bacterial. So how to manage it? Shall I make it a poll or I shall answer it as well? So this question was choose the least appropriate, choose the least one which you cannot give. So the answer of this question is antihistamines. Unfortunately, a lot of patients with COMT sinusitis, they give them antihistamines. Antihistamines actually will worsen the conditions because it will make the mucus more thick and it will aggravate the cough. So you should give a broad spectrum antibiotic. You should give a mucus thinner or mucolytic. Nasal steroids also work very good, even if the patient has no allergic, but it's a good anti-inflammatory for treating and post-cough suppressant, especially at night time to minimize the cough caused by post-nasal drip.